बैठ बताऊं बंद नहीं ले आऊं बताना हाँ बंद में खुल रहते मीटिंग का
We'll start again. So I think the good afternoon. I think I was on mute and some people could not hear me. So I will just start again, just go over. I'm Dr. Satish Nair. I'm an ENT and head and neck surgeon at the Apollo Hospitals group in Bangalore here. My special area of interest is head and neck surgery, head and neck oncology, endoscopic head and neck surgery, and robotic surgery. Today I'll be talking about a very important organ and diseases related to that, especially the surgical aspects about it, and that's about the thyroid gland. I'm sure most of us have, come across patients who come with some amount of thyroid problems, maybe medical problem or a surgical problem. So just to go through the initial phases, what is the thyroid gland? We all know it's an endocrine organ or a gland that is situated in the lower part of the midline of the neck. It has two lobes, the left and the right, connected in between with the isthmus. Behind it is the trachea, and above it is the larynx of the voice box. So this is a normal thyroid gland. What is the importance of this gland? Well, the thyroid gland, the importance is it produces hormones. The hormones are specifically the T3 or the T4 or the thyroxine, as well as calcitonin. So most of the time when you ask the patients come to us, we talk about evaluating the thyroid gland, we talk about evaluating the hormones. The most important ones are the thyroxines, the T3 and the T4. It's there in the blood in two different forms, the T3 and T4. So when you ask for evaluating a patient of the hormones, we usually go for a T3, a T4, and a TSH. So TSH is a thyroid stimulating hormone. It's what gives the negative feedback or control of how much of the hormone should be produced. That is, if T3 and T4 at high levels, the TSH would be low. And in patients who have low hormone, the TSH will be high. So generally a hypothyroid patient, when it comes to you, you'll find the T3, T4 low, but you'll find the thyroid stimulating hormone at a higher level. That's a general pattern. The other hormone produced by the thyroid is calcitonin, along with the parathyroid hormones. The parathyroid gland produce hormones are involved in the calcium homeostasis. That is the amount of calcium in the body, and how that should be maintained. So coming over to the next condition, that is a hypothyroidism. So this is one of the other common things that you find most of the people coming with hypothyroidism as compared to hyperthyroidism. So what is hypothyroidism? Generally, people have, dry hair. They always talk about increase in, reduced appetite, but increase in weight. Sometimes the thyroid can be enlarged. As the metabolic rate is reduced, low heart rate, cold intolerance, dry skin, brittle hair, depression. So these are there are many more symptoms which can be present in patients of hypothyroidism. Usually they evaluated with the hormone status, and adequate medication in the form of thyroxine supplementation is given. Whereas the other thing can be hyperthyroidism. There are less number of patients that we find hyper as compared to hypothyroidism. So hyperthyroidism, it's the opposite. There's increase in the hormonal levels. There can be sometimes enlarged gland again in this because of a particular gland producing increased amount of hormones. A lot of perspiration. Patient has sweaty palms, anxiety, palpitations, some amount of tremors, hand tremors. And various other such symptoms are seen in case of hyperthyroidism. And many patients may require, in the case of hyperthyroidism, medication. And if the medication does not able to control, may even require a surgery. Now coming to thyroid nodule, which is another the basic topic that I would like to talk today about. A lot of patients are seen with these kind of nodules, swellings in the neck. They may be a very small, subtle kind of a swelling like this, a larger one, or they may come with large thyroid swellings. So as soon as there is a swelling in the thyroid, everybody is worried about what it means. So let me tell you that nodules in the thyroid are common in women as compared to men. So during the various stages of the women's cycles, the physiology, there's a lot of thyroid hormone that is required to be produced. During the menarche, during the adolescence, during childbirth, pregnancy, etc. Due to which the thyroid gland increases and decreases in size because it requires to produce more amount of hormones. And due to this, there are always chances of having nodules, especially in women. Such nodules are usually not seen in men. Why I'm trying to emphasize this is an important part. So it is seen that, I mean, the literature says if you take women above the age of 50 years of age and do an ultrasound on all the women, you may find 50% of them having some nodules. But then that does not mean all these nodules are bad. A majority of them are benign nodules. And I said it's due to the normal physiology of life of a woman, due to which these nodules may be produced in the thyroid gland. But then when there are larger nodules which are actually seen and which may also start producing symptoms, then we need to evaluate them. Why do we need to evaluate them? We need to know whether they are having any evidence of tumor or cancer in that thyroid gland. As we all are aware nowadays that any lump or bump in the body which persists for some amount of time, we are in a situation that we want to identify what it may be. So how do you identify what are the basic investigations or basic tests that you would like to perform to identify a problem in the thyroid? Well, most of the time the patients come, the three basic tests that are required. One is to do a thyroid hormone testing. Like I said before, a T3, a T4, and a thyroid stimulating hormone. This tells us about the functioning of the thyroid. It says, is the gland increase in size because there's less hormones trying to produce more? Or is it a hyperthyroid state due to which there's something producing more? So this gives us an idea about what is the status of the gland. The next test is a simple thing called an ultrasound. An ultrasound is an excellent tool in thyroid as compared to any other part because it gives a lot of information about how the gland is, what type of gland it is, and it almost today can give you a presumptive diagnosis or what kind of nodule it may be. So the ultrasound is a way of identifying the type of gland, if it's enlarged, what type of, is it cystic, is it hard, does it some other character. So there is a system by which we say there's a TIRADS classification. So the good your ultrasoundologist, once you send for ultrasound of thyroid, will usually write a TIRADS classification in the end after writing the various. So what is he looking at? He's looking at the composition, echogenicity, the shape of the nodule, margins of the nodule, and the various foci. So there are various points given to each of this, and these points add up to the various types of TIRADS that are. So it can be a benign, it can be not suspicious, mildly suspicious, moderately, and highly suspicious. So the ultrasound report would generally, in today's day, when you send an ultrasound of thyroid, should involve a TIRADS classification to tell you what type of what you're trying to look at. And this almost gives you, for example, if it is moderate suspicious TIRAD 4 to TIRAD 5, it may be highly suspicious for a malignancy. The next test after the hormone and the ultrasound is a fine needle aspiration cytology. So the first test told us about what is the functioning. The second ultrasound told us how big it is or small, what type it is, how many nodules are there, and what would be where and all it is going. Is it going above, below, pressing onto some structures, etc. It also gives us a TIRAD classification. Now we want to know, yes, we know the structure, but can we get a small biopsy out of it to identify what it is? FNAC is again an excellent tool in thyroid because it has a high sensitivity as well as specificity. A fine needle aspiration cytology using a very fine needle, and especially ultrasound guide, if it is done, it will exactly be clear. So most of the time we find a large nodule or a large thyroid swelling and we say get an FNAC done. So most of the area may be cystic, and if the FNAC goes and hits an area which is cystic, it may just not give an adequate report. An ultrasound guided FNAC would like to touch exactly that area of the nodule or that area which is looking suspicious and take the needle. So I would suggest, if you have a suspicion for the nodule being cancer, it is prudent that you would ask for ultrasound guided FNAC, a fine needle aspirant cytology, which has a very high level of sensitivity and specificity in identifying thyroid cancers. So does this also have some grading? Yes. So again, the FNAC also has a classification. The reports on FNAC, usually you'll find the pathologist giving a BETHESDA classification. So you may say, one, either it is non-diagnostic or we could not get the adequate sample, which means repeat it. Next two would be a benign. That means it's most probably a colloid nodule. Nothing much needs to be done if it's not having any system features of cancer. 3 and 4 are atypical lesions or undeterminate lesions, where we are not sure, the FNAC is not sure whether it is a normal or it may have cancer. 5 is suspicious for malignancy, and 6 is definitely a malignant. So 5 and 6 are very clear. 3 and 4 are an intermediate range that we're talking about. So what do you do about this? So 1, we know we need to repeat category 1. 2, benign, we can keep the patient on follow-up. 3 and 4, there are further tests that are available to evaluate whether there is malignancy, but they are time-consuming as well as expensive tests. So many times patients may, in these conditions, go for a surgical option, especially if it's involving one lobe. Test this like in a hemithyroidectomy of that particular part. Test the thing on table, which is called a frozen section, which may give a positive or a negative report. And if positive, would go through a complete thyroidectomy. If not, would only remove that particular part. But like I said, there are also tests available to identify 3 and 4 as to whether they have malignancy also. 5 and 6 obviously are suspicious and malignant, would require a surgical treatment. Is it only these ultrasound and the FNAC that tells us? When we are in a problem or we are not able to identify, there are areas like the undeterminate stage, the other things that help us in identifying what treatment is required. For example, there are some clinical indicators for malignancy. For example, in history of the patient, there's history of head and neck radiation, male sex. Like I said, usually thyroid nodules are not present in male. So when you see a thyroid nodule male, you should be more careful, more vigilant, and definitely evaluate, and not say you can wait for till it grows up or something like that. Because most of the time, a nodule in a male is usually a malignant one than not. Whereas a nodule in a female would be most probably non-malignant. Okay. Extremes of ages. So if you have a nodule in less than 20 years and more than 70 years, again, extremes of age, there's a high chance of having malignancy. Others are sudden growth in size, family history of it is there, and some symptoms like symptoms of compression. So a normal nodule will cause compression, but not cause effects like not able to swallow. So if it goes behind, it presses onto the foot pipe. That is the esophagus, dysphagia. If it involves a recurrent laryngeal nerve, there can be hoarseness of voice. If it goes into the windpipe, if it's a malignancy which is invading, the patient may present first with hemoptysis. Also on examination, there are some features like larger nodules, more than 4 centimeters in size. And you find this nodule fixed and hard. In addition to the thyroid itself, there may be also cervical lymph nodes which are palpable, which again gives us an indicator, maybe yes, this patient may be having malignancy. Vocal cord palsy, like I said, extension into the trachea, which is causing intraluminal extension. So these are the conditions where we know on examination itself that we are dealing with a malignancy. So what are the various surgical aspects that we can do in case of a thyroid? So normally, thyroid surgery, which is one of the oldest surgeries that has been known, involves, like I said, thyroid has 2 lobes. Most of the benign conditions may require, if it's only 1 lobe involved, just remove that single lobe, or called a lobectomy earlier. It's actually hemithyroidectomy. To remove on one side of the thyroid. In medical conditions, sometimes where you have Graves' disease and the complete both the sides of the thyroid are involved and are causing, you may require to do a subtotal. So you leave a little bit of thyroid behind, a subtotal thyroidectomy. All the cancers have nothing else other than total thyroidectomy. There are definitely conditions, very specific conditions, where we may do a hemithyroidectomy in a cancer, but those are specific ones only. Otherwise, most of the malignant conditions require a total thyroidectomy. That's the minimum required. They may be added with some neck dissection, for example, a lymph node dissection of the central compartment, or if lymph nodes are present on the lateral neck, they may require lateral neck dissection too. So let me come back again about the thyroid surgery. Usually, single lobe involvement of a benign condition, a large one which may be causing the pressure, can be treated with a hemithyroidectomy. As we need to have a cancer, if it's a treatment of a cancer, it's usually a total thyroidectomy plus a neck dissection. Which are these patients who come for surgery? Well, this is something that I feel that these are what the patients who come for surgery for thyroid surgery. One, definitely the indication is clear. If it's cancer, yes, this group of patients require thyroid surgery. Number 2 is medical conditions not treatable by medicines at all and not been cured when Graves' disease, hyperthyroid state may require thyroid surgery. Third are the ones with pressure symptoms. Large thyroid pressing onto the trachea, the esophagus, going substernal, causing obstruction of the vessels. So the patients with pressure symptoms definitely require thyroid surgery. Fourth is a group where it's non-diagnostic, for example, as I mentioned before, and patients are having an undeterminate state in which the FNAC says they may require a hemithyroidectomy, a check with a frozen section on table, and maybe go ahead with surgery. The next 2 groups, the anxiety and the cosmosis, these are the very interesting groups. And these are usually the ones which come to us a lot of times. Anxiety. So we see a patient with a thyroid nodule, a lady with a thyroid nodule. We do all the tests and we find out that the patient is having only a benign condition. And we tell the patient, please remain on follow and we'll see how it goes. But most of the time, many of these patients will come back and say, doctor, please. So this is anxiety talking about it, not the medical reason for it, because maybe it'll turn into cancer later. So there is, though even we try to explain the chances of the cancer being very low in these patients, and the growth may be very slow, but then there is definitely a group of patients who do come up finally and get surgery done, a part of thyroid or hemithyroidectomy done. That is about anxiety in the patient, even after sufficient explanation. And the last is cosmosis. It's again getting a very popular thing nowadays. Nobody wants to roam around with a swelling in the neck. So it's only for cosmetic reasons. It's a benign condition. FNAC says it's a benign condition, but then no, we do not want to see it here on the neck. So we wanted to cause. So the last 2 are not the actual or the actual indications that I would say, but then they also exist. Just a few words about what's happening in thyroid or thyroidectomy. As I said, it's about it's one of the oldest techniques. In the olden generation itself, you can see photographs where they've been showing thyroidectomy being performed. And Theodore Cocker, he's got a Nobel Prize about in physiology and medicine is because of his work on physiology, pathology, and surgery in thyroid. So when we talk about thyroidectomy, we talk about Cocker. Now, many of us do know thyroid surgery is generally performed. We all know that you give an incision right in the front of the neck, just below the Adam's apple, and that is the area we, approach the thyroid because central, and we remove the gland. But as of today, there are so many approaches that are available to tackle the thyroid gland. Most of them are not used regularly, but then that's what I would just tell a few that can be performed. So there are more than 20 approaches. The first one is cervical approach that we talked about, the most common one. The extra cervical approaches, that means not from the neck. So you reach the thyroid from various other areas. So you can come from the back of the ear, you can come from the chest, you can come from the axilla. So you approach from this area, you give an incision in these areas far away and reach the thyroid gland. Why do you want to do it? You don't want a scar on the neck. There's nothing else more important than that. People do not. So cosmesis being important, so you want to reach the thyroid gland from other areas where the scars are going to be hidden. The third approach that is there, nodes or natural orifice. So you don't want to use a incision at all. So you want to go through one of the natural orifice and then use that as a way of doing thyroid. So transoral natural orifice is also a method which is being used extensively, especially in the Southeast Asian countries where they do thyroidectomy by natural orifice methods. So all these other than cervical approaches, which have approaches from further away, not from the center. When you want to come from far away, hide the skin, you can't reach them by direct vision. So you need something else. So you need an endoscope. So you have an endoscope here, which can be used to see and do surgery, or you need a robo. So you have arms of a robo which go to that particular place and perform the surgery. So, like I said, the various approaches can be post-oral. So you can give an incision in the skin hairline here and come and hit the thyroid gland. You can go from the axilla, one side or both sides, and also transoral. So this is one of the methods of showing a post-oral incision, one of the cases we performed here. And this is the scar. You can see a scar here in the hairline. Once the hair falls, you don't come to know. So we done thyroidectomy in this lady through this post-oral approach behind the ear. There's no scar at all. You can see there's no scar in the center at all. There's no scar. Similarly, the other one is through the breast. One is the back of the ear, the other one is from the breast. So you can have from the breast approach to the neck. So use an approach the thyroid swelling from the breast and the axilla. Again, endoscope or robo can be used to reach this area and surgery be performed. So here we are seeing this surgery being performed on the monitor. So we cannot see a direct way. That's why we need an endoscope or a robo to reach that area to perform surgery. Again, performed in a hospital here. So again, robotic thyroidectomy. If not an endoscope, a robo needs to be used. This is the other one called transoral, the natural orifice. So from the mouth, the incisions are given here, and through that you can access the thyroid gland. So I'm sure many of you must be thinking, why do you need to do this? I think I told you it's basically cosmesis, but what are the indicators? Can we do it for every case, like that big thyroid that I showed you the other day? Can we showed you in the previous picture? Can we do that? No. So indications are, first of all, it's actually only for benign conditions or a very low grade papillary. So it is actually contraindicated for a malignancy. Again, it should be less than 3.5 centimeters. So if you have a gland which is more than 3.5 centimeters, please do not try and do a robotic or a endoscopic method. So it's for small nodules where the patient wants cosmesis and it's a benign condition. So why robotic or endoscopic? Do you want this in the neck or do you want this? So I'm sure the answer is there. It's about aesthetic. So performing the advantage of using an endoscopic or a robotic technique with a mini incision or incision far away, a hidden incision, is to hide the incision from the neck so that the cosmesis and the aesthetics remain. So with this basic idea of thyroid surgery, I'm sure I can take some, all of you would be having some questions to ask. Can I hear them? So, because you're written mute all, no? You may have to unmute them. Okay. No, he's saying please unmute. Okay. So, thyroid surgery, though considered as a very common surgical procedure, which every surgeon, general surgeon, ENT surgeon, cancer surgeon, oncosurgeon, everybody performs. It's also in the domain of the head and neck surgeon. So the type and the results of thyroid surgery have changed over the years. Earlier, it was about going and removing the thyroid gland. And the most important was to preserve the recurrent larynx. The only thing was important was if you preserve both the recurrent laryngeal nerve and remove thyroid, you are the best person and you can do it. But today's thyroid surgery has changed a lot. It's become a very specialized thing because it's not just the recurrent laryngeal nerve that we need to save. We need to save the external branch of superior laryngeal nerve too. Well, this is the superior laryngeal nerve which comes close to the upper polar thyroid, which is supplying the cricothyroid muscle. Many of the patients after this surgery who have lost the superior laryngeal nerve will be having a low tone in the voice. They're not able to raise the voice, which is generally not known because you ask the patient to speak, the voice is normal, a normal speech. But whenever, if they are professional speakers, singers, they'll definitely have a change in the voice tone. So it's not just about preserving the recurrent laryngeal nerve, it's about also preserving the external branches, superior laryngeal nerve. Another important thing, especially in a total thyroidectomy, is to preserve the parathyroid. Again, not just preserving the parathyroid gland, but to preserve the parathyroid gland with its blood supply, which is the basic thyroidectomy requirement of today. So the recurrent laryngeal nerve, the superior laryngeal nerve, as well as the parathyroid. So we can, I think they're not, maybe I'm very clear or or I've not been able to explain at all. So anyway, I don't see much of questions now. So I think we'll close it here. Thank you.